Welcome everyone to today's session of our neuro-oncology wellness series. We will be learning about IDH-Mutant Gliomas in this session, which is moderated by Rachel Garcia-Fox and led by Dr. Youssef. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the Now team for this continued partnership. The recording of this session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center. For those of you watching live, if you have any questions related to today's program, please feel free to utilize the Q&A feature or the chat feature throughout the session. At the end of the session, we will use your questions to moderate a brief Q&A. If you have any other questions or would like more information about resources and programs offered through the Blum, please visit our website at www.dana-farber.org/resource-center, or you can email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now pass the workshop over to Rachel.
Thank you, Becca. Hi, everyone. Welcome to today's Neuro-Oncology Wellness Education webinar. The Neuro-Oncology Wellness, or NOW, program is a new initiative from the Center for Neuro-Oncology at Dana-Farber Cancer Institute with a mission to educate patients and their caregivers about brain tumors, as well as provide resources to promote overall health and well-being. My name is Rachel Fox. I serve as the program administrator for NOW, and I'll be your host for this series. Today, I am very excited to be joined by Dr. Gonzalez-Castro and Dr. Youssef for a discussion on IDH-mutant gliomas. Dr. Gonzalez-Castro is a physician scientist at the Dana-Farber Center for Neuro-Oncology, where in addition to caring for brain tumor patients, he is active in basic and translational research, studying both glioblastoma and IDH-mutant gliomas. Dr. Gonzalez-Castro also serves as the director of the Neuro-Oncology Wellness Program. Dr. Youssef is a neuro-oncologist at the Dana-Farber Cancer Center for Neuro-Oncology and an associate neurologist at the Brigham and Women's Hospital. He cares for patients with brain tumors and patients with neurologic complications of cancer and its therapy. In addition, Dr. Youssef is interested in improving the neuroimaging assessment of response to brain tumor therapy, having contributed to several studies in this area. Drs. Gonzalez-Castro and Youssef, thank you so much for joining us today.
Thank you, Rachel.
Before we start, I just want to remind our live audience that we want you to be a part of this conversation by submitting your questions via the Q&A feature at the bottom of your Zoom screen. We will select a number of your questions for our guests to answer in the second half of our program. Without further ado, let's get started. Dr. Gonzalez-Castro, why don't we start right at the beginning? Tell us, what is an IDH mutant glioma?
Thank you, Rachel. That's a key question that requires quite a bit of background to really understand what we're talking about when we discuss this class of gliomas. But I feel that often in our clinic visits, we just start talking about the IDH mutation and our patients don't have enough background to really understand what we're talking about. So I thought we'd take a few minutes to paint a picture of what mutations and cells and cancer are all about, because we study cancer and we treat cancer as part of our daily work, but many patients and caregivers are not familiar with this concept. So I like to think of the idea of a city, because everyone has seen houses and cities. So let's imagine the human body as a city, and let's imagine organs of the body as neighborhoods with many blocks of houses. And let's think of cells as houses. And cells are very special in the sense that each cell inside the cell has the blueprints of how to build that particular house and any house in the neighborhood or the city. And those blueprints need to be followed very faithfully to end up with a house that has all the features that we're thinking about. And the blueprints not only include the way of building the house, the walls and the bedrooms, but also all the furniture and appliances that are inside the house. So It is because of issues following the blueprints to build this house and all the appliances inside the house that problems like cancer come about. Cancer is a disease in which through the accumulation of different changes in these blueprints, as another house is built, the blueprints have to be copied over, and oftentimes a mistake is made. So things are not built to the specifications, the original specifications, and things don't work in the same way. So as I mentioned, the blueprints, give you instructions to build the walls and everything else, but also give you instructions to build the appliances. So cells have structures that form the cell itself, but they also have all these quote unquote appliances or machines that we called enzymes. And IDH or isocitrate dehydrogenase is an enzyme that is associated with metabolic functions, with how the cell provides energy for itself. If you want to think of it using our analogy, it's a kitchen appliance. But in the mutated version of the enzyme, the appliance is not working in the way that it's supposed to, and is building up byproducts that lead to cells or houses growing more rapidly in the neighborhood, and leading to problems as one house starts to run into another house, and the houses themselves start altering the function of the whole neighborhood. Houses are growing into rows and cars cannot go by, and this is the essence of what we're talking about when we talk about an IDH mutation, is a change in the blueprint that is used to build a specific element that is part of the function of the normal cell. And as a result of that change, we see the uncontrolled growth of cells that lead to disruption of brain function. So the interesting thing about this mutation is that in this class of diseases, we think of this mutation, this change in the blueprint, as an initiating event, one that sets things in motion to the cell growth and to the eventual impairment of function caused by the tumor. And I mention it because we'll discuss it, I imagine, later on. That is a very attractive element to try to target, to try to revert the changes that are brought up by this mutation.
Thank you so much for that. The analogy is particularly helpful for those of us that are visual learners. So can you tell us a little bit more about the significance of mutation with the IDH enzyme?
Yes, so the enzyme itself, when it functions in a normal way, it helps in the process of producing energy for the cell. However, when mutated, it produces a substance that modifies the structure of the blueprint itself. The blueprint for the cell, the way that DNA is arranged, has a special physical structure that enables the reading of the blueprints, and that is modified through the substance, the abnormal substance that is produced by the mutation. So what happens is that normal proteins, these are other machines within the cell that are involved in cell growth and have a role in cell growth during different times of our lifetime, such as in development. When we are forming our brains, when we are in utero, and even when we're children, these cells need to divide to populate the entire brain and help establish the normal adult structure. And then the activity of those proteins should stop because the brain is encased in a hard surface that is not flexible, and there's no room for growth there. So once the adult brain is fully formed, there is no need for the activation of these other proteins. But because of the mutation itself and the changes it causes in the way that the blueprint, the DNA blueprint is read, some of these other enzymes, some of these other proteins get activated and lead to cell growth. So that's how we currently understand the effect of the mutation leads to cancer.
Thank you for explaining that. It's a very comprehensive answer. Why don't we zoom out a little bit now? Dr. Youssef, how common are IDH mutant gliomas? And do these tumors develop at any particular age?
Thank you, Rachel, and thank you, Dr. Gonzalez Castro, also for inviting me to this amazing initiative. So brain tumors in general, and especially primary brain tumors, which are tumors that actually started and grew in the brain, are actually rare in general compared to the other cancers in the body. And when we talk about IDH-mutant gliomas in particular, they're also not the most common type of tumor that we deal with. And actually, among all the gliomas that we deal with, the IDH-mutant gliomas might constitute about 10 to 15% of these tumors. Now, in general, like if we don't have a lot of what we call epidemiologic data on the IDH-mutant glioma itself, because the molecular era and the IDH mutation identification just like started a few years ago. But if we take 1 million people, for example, every year, we can estimate that around 7 to 10 of them would develop an IDH-mutant glioma per year. Now, with IDH-mutant gliomas, we have mainly two types, as we learn. We have a type that we call astrocytoma and another one that we call oligodendroglioma. And these two types are mainly differentiated by how they look like under the microscope and what kind of mutations or genetic profiles they portray. And we know that astrocytomas are usually more common than oligodendrogliomas, and especially if we talk about the lower grade, grade 2 and 3, which is mainly like what we see in both tumors. Now, in astrocytomas, we usually have grade 2, 3, and 4. And when we say grade, we mean how aggressive the tumor is, meaning how quickly the cells are dividing under a microscope, and what kind of mutations this tumor cell carries, and whether these mutations makes it aggressive. In oligodendrogliomas, we only have grade 2 and grade 3. Now, usually these tumors develop over the, I would say, 4th or 5th decades of life, meaning patients would be in their 30s or their 40s. In astrocytomas, mainly the patients would be towards like their 30s. In oligodendrogliomas, it's mainly patients who are in their 40s. But this is typically the age that where we diagnose these tumors. And typically, we do see these tumors more commonly in males than in females.
Thank you for that very helpful information. So let's talk a little bit more about how patients come to learn about the presence of a tumor. What are the most common symptoms experienced by patients?
Sure. So the main symptoms, actually, when we talk about brain tumors, the symptoms would mainly reflect the location of the tumor, as the same tumor can cause different symptoms, depends on where it's located in the brain. In IDH-mutant gliomas, by far the most common presenting symptom is a seizure. That's usually mainly a focal seizure, meaning involving one arm or one leg, or like speech arrest, for example, patients having some abnormal smells, some auditory or visual like changes or so. But sometimes we can have other types of symptoms, including headaches, for example, that mainly occurs from the buildup of pressure that this tumor can cause in the brain. But also we can have any other symptom, again, depending on the location. We can have weakness or numbness in an arm or a leg. We can have some visual problems. Either it's a blurred vision, double vision, or even visual field cuts. We can have problems with speech, problems with balance, you name it. And usually these symptoms, especially in lower grade tumors, they develop over the course of weeks. They don't usually like acute, except for the seizures, of course. Now, that being said, in a lot of the cases, actually, the IDH-mutant gliomas can be diagnosed incidentally. So patient would be doing a brain MRI or head scan for a totally unrelated reason, such as potentially maybe migraine headaches, or like patient who had a head trauma or had a car accident, and we're just evaluating them for any complications. And we do a head scan or a brain MRI, and we find this kind of lesion on the imaging, and this would lead to the diagnosis.
Thank you for that. Sounds like there are a variety of ways that these tumors can present in symptoms in patients. I'm wondering, you said something about seizure activity being common in this population. Dr. Gonzalez, why don't we go over to you now? How common are seizures in patients with IDH-mutant gliomas?
Very, very common. The estimates range between 70 and 85% of patients with IDH-mutant gliomas presenting with seizures. And over the life of the disease, patients, almost 100% of patients develop seizures. One of the reasons that we think seizures are most common in these patients is because the abnormal substance produced by the mutant IDH enzyme is very similar to a neurotransmitter that exists in the brain, and it can come out of the cell and can change the resting electrical potential of cells in the brain and make them more likely to fire. And firing brain cells that fire in a synchronized way is essentially what a seizure is at the level of the brain. So a very important goal in treatment of IDH-mutant glioma patients is good seizure control, because this contributes to overall better quality of life. We want our patients to resume their normal activities and their normal lives. So we work very closely with our patients in our visits to try to understand, as Dr. Youssef said, a seizure can at times be something focal, restricted to a particular area of the brain, and might not be what we all think sometimes when we think of a seizure as someone losing consciousness, falling down to the ground, having abnormal movements. It could be something very subtle, just like this subtle twitching of one or two fingers in one hand, or can be an abnormal sensation, a sensation of déjà vu, of thinking of something and having the experience of, have I been here before? Have I experienced this before? That's that sensation. Abnormal smells with seizures located in the temporal lobe. Those are also things that patients sometimes note to us. So we take a very careful history, and when we have evidence of seizures, we treat them. We have very effective ways of treating seizures these days. We have over 15 or more anti-seizure medications. They all are effective to different extents, and they have different side effect profiles. So we're careful in trying to select the medications that will lead to the best possible seizure control and not make patients tired or irritable, which are some of the side effects that are often reported with the medications we use.
Thank you. It's very helpful to have that background information. Dr. Youssef, let's talk about initial diagnosis. Let's say somebody arrives at the hospital, they've had a seizure or some other symptom. What happens when they get there?
Sure. So I'll first start by someone who might be having an active seizure, and then maybe we'll kind of include patients who might have had a seizure or presenting with other symptoms. So if a patient is presenting to the ER with an active seizure, the first thing we have to do is to make sure that the patient is breathing on their own, make sure the patient is stable, meaning that they can maintain a good blood pressure, they have a good heart rate, they can maintain a good oxygen level in their blood, just to kind of like make sure that everything's okay and there's no kind of immediate compromise on the life of the patient. And then once this is done, we usually would try to abort the seizure. And by abort, I mean that we try to stop it. Now, most of the seizures actually stop on their own without any interventions, and most of the seizures actually might only last for seconds or minutes. But if we see that a seizure is not actually stopping on its own, we give some medications to stop it. These medications include initially some benzodiazepines, for example, like Ativan, but also we use the anti-seizure medications that Dr. Gonzalez Castro was alluding to. And then once we kind of abort the seizure, the patient is stable, we have to consult a neurologist, or they have to be evaluated by the neurologist just to kind of like evaluate what kind of deficits they have. And we have to run some blood tests to rule out some electrolyte abnormalities or some glucose blood sugar problem that might trigger the seizure. Now, after this is all done, we know that in every patient who present with a first-time seizure in their life, we have to look for any potential organic cause or any kind of acute process going on in the brain. And that's why we have to do a brain imaging, whether it's head scan or brain MRI. Now, if a patient had a seizure and presented to the ER after like they're back to normal, or if the patient is presenting with like few weeks of progressive weakness or any other focal neurologic deficit, we kind of do the same. But obviously, we don't have to give any medications to kind of abort the seizures, obviously, if they're not seizing. So now that when we do the head scan or the brain MRI, obviously, if you have to pick one between these two modalities, we prefer the brain MRI, just because it gives us better kind of details of the brain, and it helps us better characterize whatever process might be going on in the brain. And sometimes if we do only head scan and we find something that's not very clear but shouldn't be there, we obtain a brain MRI for a better characterization. Now, on the brain MRI, the IDH-Mutant Gliomas, they typically present kind of a mass-like lesion. We call them expansile, meaning that they look kind of expanding, and they're pushing the adjacent brain structures kind of like outwards. And these lesions, they can or not take up the dye when we give the contrast. Traditionally, we used to think that if a tumor doesn't take up the dye, then maybe we're dealing with a lower grade tumor. But if there is actually uptake of the dye, maybe it's a high grade tumor. But the kind of like this differentiation does not really apply all the time. Now, as for the location of the lesion, we know that these tumors can occur anywhere in the brain. They can also occur in the brainstem, which is kind of like the connection between the brain and the spine as well. But in IDH-Mutant Gliomas, they mostly occur in what we call the frontal lobes, which are the anterior part of the brain. And in any way, once we have any lesion, regardless whether it's in the frontal lobe or any other lobe, we have to kind of investigate what kind of lesions we're dealing with. And this is when we typically consult neurosurgery.
Great. Okay. Dr. Gonzalez Castro, let's talk about that a little bit more. What are next steps for somebody who's, maybe ready to get surgery for their IDH-Mutant glioma?
One thing to highlight regarding what Dr. Yusuf just discussed is that we can get a very good idea of what is going on just by looking at the MRI, but we cannot make a diagnosis with MRI alone. The diagnosis of a glioma, IDH mutant or otherwise, is established through analysis that are done on a tissue sample that is obtained by a neurosurgeon. So in IDH mutant gliomas, we have very strong evidence now that show that trying to remove as much as we can see of the tumor on MRI, these are tumors that grow out of the substance of the brain and infiltrate the substance of the brain. They're never completely removed through surgery. But if we can remove everything that we can see, those bright areas that show up on the T2 sequences of the MRI study, patients will do better over time. So it's important to work with our neurosurgical colleagues, which here at the Brigham and Women's Hospitals and Dana-Farber are very experienced, very dedicated to operating in the brain for the removal of brain tumors alone. So it's important to, if there is a concern of the presence of a tumor in the brain, to consult with an experienced brain tumor neurosurgeon, because outcomes vary. Surgeons that are repeatedly operating in the brain to remove tumors tend to do better in terms of removing more tumor and tend to have less complications, which is something that we fear and we don't see all that often. But as you're trying to cut away an abnormal piece of the brain from the healthy brain, there's always a risk of injury to the healthy brain. So we want our patients to be seen by experienced neurosurgeons to undergo what we call a maximal safe resection, which is the removal of everything that we can see on MRI that can be removed safely, that is without causing any problems after the operation. And then after the operation, the tissue goes to the pathology department. There are many things that happen there, but essentially in one bucket, there is the creation of tissue slides, very thin slices of tissue that is looked at under the microscope, and that can provide a lot of useful information. We can see abnormal cells there. We can see other structures like small blood vessels that sometimes are associated with tumors. We can see areas of dead tissue that sometimes are present in tumors. And then the other part of the analysis involves taking DNA from the tissue sample itself and looking at specific sequences and trying to identify what are the mutations or other changes in the DNA structure that are present there. With all that information combined is that we provide what we call the integrated diagnosis. And when patients come, we'll learn the name of the tumor, oligodendroglioma or astrocytoma. They will learn about the presence or not of an IDH mutation. They will learn also about grading, which is a way that we have to assign, a measure of aggressiveness of the tumor, with grade 2 tumors being less aggressive and grade 4 tumors being more aggressive. So then after that entire process, we meet again with our patients and we help them digest all that information, explain to them what it means for them and what the results of the analysis mean in terms of how to proceed with additional treatments.
So the molecular testing is particularly important for that diagnosis.
Critical. These days it is critical. And we do it routinely here at Dana-Farber. At other institutions, sometimes they do a limited analysis. So when patients come for a consultation from other centers, we always repeat the molecular analysis on our patient samples because we want to make decisions based on the best information regarding what we know about the tumor. So the World Health Organization that we all heard about a lot through the COVID pandemic, in addition to help dealing with epidemics and pandemics, helps organize information about all kinds of cancer. And they publish a book with a classification of tumors of the brain and the spinal cord. And the most recent edition from 2021 particularly highlights the importance of all the molecular analysis that are done on tumors to really get at an accurate diagnosis.
Great, thank you for that information. So you mentioned that, we want to get out everything we can see on the MRI, but that you can't get everything out. What did you mean by that? And, is there anything else that you would do to handle treating the tumor?
Yes, we, as I mentioned, these are tumors that grow the substance of the brain of glia, which are cells that are supporting neurons. We have neurons and glia in the brain mostly. Neurons are the working end of the brain, the cells that have very defined electrical activity that work like a computer circuit. And then we have supporting cells, the glia, that are there to help the neurons stay healthy. The gliomas grow out of the abnormal cell growth of glia. And as this is a tumor that comes from the normal substance of the brain and infiltrates the brain, it can never be completely removed through surgery. There are always cells left behind. And these are cells that cannot be seen under the microscope when a surgeon is operating. So additional treatments are required. And these are the treatments that we discuss with our patients. And I'll let Dr. Youssef, mention what are the treatments that we often discuss with our patients.
Yeah, please, Dr. Youssef. What are these additional therapies and what do they involve?
Yeah. So as Dr. Gonzalez eloquently mentioned or discussed, that first and foremost, we have to do a surgery both for diagnostic and therapeutic purposes. But often surgery might not be enough and patient might require more treatment. And typically we rely on some guidelines to kind of guide us to how we treat particular patients. And the treatment actually differs among patients depending on the grade and depending on the extent of resection, meaning how much of the tumor has been taken out or resected. So let's start. I'm just going to kind of divide this answer by grades just to make it a little bit easier. So if we're dealing with a grade 2 tumor, meaning that this is the grade, we did everything and all the tests and the integrated diagnosis is that it's a grade 2, meaning the most benign among of these tumors, or like the most benign grade. So we typically characterize patients of this grade with like what we call a high-risk patients and low-risk patients. And to do this, we kind of rely on some clinical variables that have been kind of found in multiple studies to kind of be associated with potentially better outcomes in the future. Now, the main characteristics for a low-risk patient is that typically a patient would be young in age, typically below the age of 40. And this limit is kind of arbitrary, meaning that it has been shown in some studies, but we still use it. We don't know exactly whether the age 40 is actually the cutoff limit or like an appropriate one. But typically, if we have a young patient who had a resection of the entire tumor, that at least with the naked eye on the brain MRI, we don't see any residual tumor on the post-operative brain MRI. And also patients who do not have any focal deficits or any symptoms from the tumors. So these patients whom we call low risk, we can just watch closely with serial brain MRIs. And we only consider treatment if we see that the tumor is coming back, or if we think that this tumor might kind of start acting up and potentially causing some problems again. Now, in the remaining patients who are either older in age, do not have a complete resection, or have some neurologic deficits, we call them high risk. We treat them as we treat any patient with a grade 3 tumor. So we treat them usually with radiation followed by chemotherapy. And this also applied to all patients with grade 3 tumors, regardless of their age and the surgery or the symptoms that they have. Now, typically the radiation spans over the course of 6 weeks, around 6 weeks. And the radiation involves treatments with like these what we call gamma rays that are given focally to the tumor. So it's not going to be radiation to the whole head. They're given on a daily basis over the course of 6 weeks, and mainly it's the weekdays. We give the patient breaks over the weekends. Now, after this radiation is done, we give them a little break for 4 to 6 weeks, and then we continue with chemotherapy. Now, the choice of chemotherapy sometimes depends on the type of the tumor that we're dealing with, and also on the practice of specific institutions. So typically, if we're dealing with astrocytoma, which is a type of the gliomas, we use a chemotherapy that comes in an oral pill form. We call it temozolomide or Temodar. And this is typically given for almost a year or 12 months. And the way that we give chemo is through cycles. So typically in Temodar, we're going to have 12 monthly cycles. And during each cycle, the patient will take the drug for 5 days a month. And then for the rest of the month, they just don't do anything. As for oligodendrogliomas, the practice kind of differs among institutions. Some institutions still use the Temodar or the temozolomide, but other institutions use a combination of 3 drug regimens or 3 agents, which we call PCV. And some of these drugs are oral in form, some others are given through infusion. And there's a little bit of nuance about the difference in the cycles. But all in all, the treatment would also be around 9 to 12 months as well. Now, if you're dealing with a grade 4 tumor, which is the most aggressive or the most kind of like the highest grade of all these tumors, again, we don't really rely on the age. We don't rely on the extent of resection or the symptoms. We have to treat the patients regardless with radiation and chemo. The main difference between the grade 4 and the other grades is that with the grade 4, we give a higher dose of radiation, and we give chemotherapy during and after the radiation, not only after the radiation like in the lower grades. And as long as the patient is getting treatment, and even after they're done with the treatment, we continue to watch them with serial brain MRIs that we usually perform every 2 to 3 months, just to make sure first that whatever we're doing is working. And second, once we're done with the treatment, that the tumor is still kind of not quiet and not really coming back or growing in size.
Are these therapies in combination effective in eradicating the tumors?
So unfortunately, so far, we tend to think that all the treatments that we have do not actually get rid of the tumor like forever. And the goal of the treatment is actually to keep the tumor at bay for as long as possible. And this is what the studies have shown, actually. So now we know that if we give radiation and chemo for these tumors, so first the radiation kills all the actively dividing cells, and then the chemo kind of continue this job. And the main goal to do so is to kind of prolong the time where the tumor would be quiet, would be quiescent, meaning that it's not acting up, it's not really causing any problems, not growing in size, not causing any symptoms. And actually studies showed that patients who actually receive this treatment or radiation and chemo compared to patients who do not have a longer interval or time interval where the tumor is actually this quiet. And not only the treatment would affect or would keep the tumor at bay, but it was also associated with improved survival in these patients. And one might wonder, like, can I do only radiation? Can I do only chemotherapy or so? And we have a lot of studies on this. And now we know that combining radiation and chemotherapy together is better than using either modality alone.
Great, thank you. Dr. Gonzalez-Castro, let's talk about the INDIGO trial. We recently learned about this large study, the INDIGO trial, treating patients with an IDH inhibitor. Tell us, what did we learn from this exciting study?
Thank you, Rachel. As I mentioned at the beginning, we think that the presence of the IDH mutation and the activity of the mutated enzyme is an essential foundational event for the growth of these tumors. So for a number of years now, there's been an interest in trying to eliminate the activity of this abnormal enzyme. And there have been a number of studies, and these are, experiments where we offer treatments to patients that we don't yet know if they're going to be more beneficial than standard treatments, such as the ones that Dr. Youssef was describing. These are done in the context of what we call clinical trials, and we're going to have an entire session, one entire now webinar on clinical trials later on this year. But the INDIGO trial is a recently finished and published clinical trial in which patients with grade 2, the lowest grade, IDH-mutant gliomas, were offered to take an IDH inhibitor. The name of that drug is vorasidenib, but essentially is a medication that affects the function of the mutant IDH enzyme. It doesn't affect the normal IDH enzymes in the cell, and prevents it from doing the normal activity that it does that leads to tumor growth, versus receiving a placebo. We often don't do placebo-controlled clinical trials in neuro-oncology because we know that these tumors are progressive over time. However, as Dr. Youssef mentioned, in grade 2 IDH-mutant gliomas, patients are often observed after the initial resection. And the reason for this is that we want to delay treatment with radiation, which over time can lead to complications in normal brain function. Radiation is a very effective treatment to kill rapidly dividing cells, but it can also affect normal brain cells and lead to their death and cause issues in terms of how we think, how we remember things, how we function in normal life. Not immediately, but often over months and years after treatment. Patients often complain of this. So patients with grade 2 tumors, patients that are in that category that Dr. Youssef described, low risk, were often observed after their initial diagnosis. So that's why in this study, patients were offered the IDH inhibitor or were given a placebo. Patients didn't know, and they were followed for a period of time. The main outcome that was looked at in this study is something called progression-free survival. And that is essentially how long can patients go having stable appearance of their tumor on MRI. And patients that were treated with the IDH inhibitor showed that their tumor stayed on average stable for 2 years and 4 months, compared to less than 1 year in patients that received the placebo. I will say also that this study was finished early because there was early evidence of efficacy, and patients that were on the placebo arm were then allowed to receive the IDH inhibitor. So they got the benefit of that therapy later on. The other important finding from this study is that patients that were on the IDH inhibitor were able to significantly delay the time until their next needed therapy, which is also a very important outcome, both to prevent the side effects that are associated with the therapy itself, both in the short term and in the long term. So I think this is a very exciting development. The guidelines that we use to treat patients with IDH-mutant gliomas will soon be changing to reflect this finding. And we trust that this new drug, vorasidenib, will soon be approved by the Federal Drug Administration, which approves any drug that is given to any cancer patient or patient otherwise, will be approved for the treatment of IDH-mutant gliomas. Another IDH inhibitor called ivosidenib is already approved for a type of blood cancer that also presents with IDH mutation. So that's a drug that is already available. But I trust that this drug, vorasidenib, will soon be approved for the treatment of IDH-mutant gliomas. And this will become the new standard of care for patients with grade 2 tumors after their initial diagnosis.
Very exciting indeed. Thank you so much for going over all of that. It sounds like there are still some questions around using IDH inhibitors for high-grade patients. So are IDH inhibitors effective in high-grade IDH mutant tumors? Do we know?
We're looking to study that more in depth, both here at Dana-Farber and at other institutions. The initial studies where they took all comers showed that in tumors that were at higher grades and had more aggressive features, these therapies were not as effective by themselves. But here and also in other centers, we're looking at combination therapies that include IDH inhibitors, and we hope that these patients with higher grade IDH mutant gliomas will also be able to benefit from these therapies as well.
Fantastic. Okay, so stay tuned, I guess, for more information on that as the research progresses. Thank you both so much for answering all those questions. This has been truly very informative. We're going to try and answer a few questions from our viewers while we have a few minutes left. So this first one here, patients oftentimes are wondering about causes. So here's a question. Are there environmental causes? Examples, exposure to toxins or electromagnetic radiation on the job?
Dr. Youssef, you want to take that one? Yes.
I can answer this question. So there have been a lot of longitudinal studies that were actually conducted over years to try to identify some potential risk factors for the development of any type of brain tumors, including obviously gliomas and IDH-mutant gliomas. And so far, the only established risk factor that we know of is a history of exposure to radiation to the brain, and like a remote history. Like the main example applies to patients who might have had like leukemia, for example, in their childhood, and they had like a irradiation to their whole brain. And these patients might be at risk of developing some like any type of brain tumors, including gliomas, in like in adulthood. We know also that in a very rare group of patients, we might have some what we call genetic syndromes or hereditary syndromes that might predispose these patients to develop multiple types of tumors, including some brain tumors. But otherwise, we don't have any other established or well-established risk factors for the development of this kind of tumor.
Thank you.
I want to emphasize that because it's a very common question from our patients. And you receive notice of a diagnosis of a brain tumor, and there's always a lot of anxiety, and patients worry that their cell phone use might have led to developing a tumor. There are no studies that show clear evidence of that. So it's only ionizing radiation, the same type of radiation we use to treat the tumor. If you receive radiation to the brain for some reason, early in childhood, then you're at an increased risk. But other than that, microwaves, TVs, cell phones, and none of those kinds of lower energy electromagnetic radiation has been associated with the development of brain tumors.
Thank you both. Yes, this is an important clarification. I appreciate it. So we have a question here. Is a glioblastoma a type of IDH mutated brain tumor?
Yeah, I can answer this too. So traditionally, Dr. Gonzalez Castro mentioned this worldwide classification that we all use, which is from the WHO in regards of brain tumors. And traditionally, glioblastoma was considered to be a type 4, a grade 4 glioma, meaning that any glioma that looks like a grade 4 is automatically considered to be glioblastoma, whether there is the IDH or the IDH mutation is detected or not. But over the course of the years, we learned that the behavior of these tumors, like even like of grade 4 tumors, actually might differ based on the IDH mutation. And we learned that a lot of grade 4 tumors with IDH mutation behaved much better than grade 4 tumors without the IDH mutation. Furthermore, even if we have a grade 2 or 3 tumor, but without the IDH mutation, they might behave more aggressively than IDH mutant tumors of a grade 4. So to kind of like put it in more perspective, having the IDH mutation per se makes the tumor a little bit less aggressive than not having the IDH mutation. So to kind of like emphasize on this, the term glioblastoma is no more used in patients who have, or like for tumors that are grade 4 and do have the IDH mutation. Nowadays, we just call them astrocytoma, a grade 4 with the IDH mutant or with the IDH mutation. And we keep the glioblastoma term for patients or like for tumors that do not have the IDH mutation and have like some features either on the microscope or in the genetic testing that kind of allow them or make the tumor aggressive and act like a grade 4. But the IDH mutation has to be absent to call it a glioblastoma.
Thank you. Okay, so a glioblastoma is what we would call an IDH wild type brain tumor.
That's
yes?
right. Mm-hmm.
Okay, great. Let's get a few more questions here. Surgery is not an option for me due to the location of my tumor, leaving very few options if treatment does become necessary. Given the brain-blood barrier, how is any medication going to truly be effective?
That is a very good question. And it is not uncommon for tumors to be present in central areas of the brain that are not easily accessible to a neurosurgeon. and that oftentimes cannot be safely removed. If you were to remove them, patients would wake up significantly impaired after an operation. It's always good to talk to a couple of neurosurgeons, because what is not available at one center in other centers can be done safely, but under the assumption that surgery is not possible, other treatments are still possible. Radiation can get anywhere into the brain and is often used as a very effective treatment to try to slow down tumor growth. And regarding systemic therapies, therapies that either are taken by mouth to go through the stomach and then be accessed into the blood and then go into the brain, or just given intravenously, getting into the blood and then trying to go into the brain directly. As we were talking about cities in the initial question and the analogy of cities, the brain is a very exclusive neighborhood. It's fenced up and not anyone can get in there, for a good reason, because the brain is the seat of, with the permission of cardiologists that tend to think that the heart is the most important organ of the body. The brain is the seat of our memory, of our movement, of oral sensation, and is the way we interact with the world. So it is protected from things that are circulating in the blood, including our own immune cells. Cells of the immune system cannot easily access the brain, because when they get revved up, they could cause damage to the brain itself. However, we understand how the blood-brain barrier works, and we understand that there are certain molecules of a certain size and of certain chemical features that are more likely to cross it and get into the brain. So the chemotherapies that Dr. Youssef mentioned early on, we know cross into the brain: temozolomide, procarbazine, CCNU, vincristine, which is an older chemotherapy that was part of a regimen that is still used in some institutions. We don't think that enters the blood-brain barrier, so we don't think it accesses the brain that well. But the other ones that I mentioned do cross the blood-brain barrier, and we know that IDH inhibitors cross the blood-brain barrier and have activity in the brain. So even if your tumor is deep, even if your tumor cannot be accessed through surgery, we still have good options to treat it and keep it from growing.
Thank you. Great. So we have two questions here about progression and grading. So do grade 2 tumors, the lower grade of these IDH mutant tumors, do they always progress to grade 3 or grade 4? And in the case of, oligodendroglioma, where we only have grade 2 and 3, what does that mean for progression?
So it's not unusual, as we discussed, for these tumors to eventually potentially become active again and grow in size. And we think that, or we tend to think that whenever a tumor has been stable for a while and then it starts kind of growing in size or so, that it might have acquired some mutations, or it might have become a little bit more aggressive than the initial or the original type of tumor. Now, a lot of times, let's say a patient has a grade 2 tumor, and then we see that this tumor is grown on brain MRI. The only reason to actually know exactly whether it's progressed to a grade 3 or 4, or transformed to a 3 or 4, or remained as a grade 2 is to do an actual a biopsy or another surgery or so. And in these patients, a lot of times the tumor remains of the same grade, but eventually we know that these tumors will eventually progress to a higher grade. It doesn't have to be always a grade 4. Sometimes it can be just from a grade 2 to grade 3. And I tend to think that the longer this patient kind of remains alive, for example, or the tumor we give the tumor more time to become to stay there, or become aggressive, eventually it will definitely progress or transform to a higher grade. Now, regarding the question of oligodendrogliomas, if it's a grade 3, what happens next? So grade 3 is actually kind of like the higher grade of oligodendrogliomas, and it is actually what we call like the more aggressive type of oligodendrogliomas. And typically, if we have a grade oligodendroglioma grade 2, it can definitely transform to a grade 3. Whereas in oligodendroglioma grade 3, if the tumor does not require some specific molecular kind of or genetic mutations, it remains a grade 3 oligodendroglioma. But sometimes the reason of this tumor coming back might or growing in size might be some molecular features or some new mutations that the tumor acquires and makes it a little bit more or make it a little bit more aggressive. And this tumor starts acting kind of like a grade 4. So even if it's technically an oligodendroglioma and a grade 3, but we treat it or we consider it kind of like an astrocytoma grade 4.
Thank you again. Okay, so it's again the moleculars. So it's really important to know what's going on with the pathology. If your tumor grows. Okay, we are short on time here. I do just want to get this one other question in because it is so applicable to the topic of today. What is the interaction between heightened 2-HG levels? So that's that molecule that Dr. Gonzalez Castro had mentioned earlier that's produced in excess by the cells in these tumors. What is the interaction between that molecule, the 2-HG, and brain cells? And do higher 2-HG levels cause IDH mutant mutations, or is it the other way around? What do we know?
2-HG stands for 2-hydroxyglutarate. This is the abnormal substance, the abnormal metabolite that the mutant IDH enzyme produces. It's a byproduct of this enzyme, but it does not cause the mutation itself. It's a result of the mutation, and it does not cause the mutation. It does cause other changes in the way that the blueprint for other cells gets modified down the line, but it does not cause the mutation.
Thank you. All right, everyone. This has been a fantastic talk. Thank you, Dr. Gonzalez Castro and Dr. Youssef, for this really comprehensive and engaging discussion on IDH mutant gliomas. We have about a minute or two for any take-home points. Do you guys have any final words on this topic?
What I can say is that now that we understand more about these tumors, we have more treatment options, and hopefully we'll have more treatment options in the future as well. What I can say is that we are all here to help, and hopefully we hope to advance the field of treatment. And to all our patients and our their families who are attending this webinar, I can say that wherever any questions or concerns that you might have, please reach out to us, and we are very happy to help and discuss any questions you might have.
I echo those thoughts. I see a question about the clinical trial drug that I discussed. This drug is called vorasidenib, VORASIDENIB, as in boy, vorasidenib. And there were two questions about other factors that can extend the interval period and can extend survival. And one of those, it's been studied, is staying healthy through the life of the disease. And the most important element to achieve that is exercise. So here at Now, we want to talk to our patients about exercise and how to start an exercise routine if you don't have one. So we're going to have a two-part seminar on exercise for brain tumor patients starting next month. There'll be more information coming. And we thank you for joining us today, and we hope that you will join us for other events of Now.
Thank you, everyone, so much for joining. We do ask, if you don't mind, please fill out that poll that's going to go out at the end of the webinar. I'm also going to paste something in the chat here now. There's a link to our sign up for getting notified about the Now program. So you will get any notifications that we have about this exercise course that Dr. Gonzalez Castro mentioned, and also our future webinars. So we do have one actually coming up soon on September 5th. It's going to be on central nervous system lymphoma with Drs. Lakshmi Nayak and Ugo Chukwueke. So we hope to see you there at any of our other programs. And again, thank you for being here today, everybody.
Thank you.
Thank you,
Yeah.
everyone. This was another great webinar, and this series has been really amazing and very accessible. I really appreciate how much of a conversation this is. So if you want to catch up, again, you can look at our Blum YouTube playlist as well as our Blum Digital Resource Center. All of the YouTube videos are posted there. And thank you all so much. Have a great day.